Good morning. Today we are going to discuss an article. The title: Once daily subcutaneous Vosoritide therapy in children with achondroplasia, a randomized, double-blind, phase 3, placebo-controlled, multi-center trial. So this article was published in the journal with an impact factor of 98.4 in the Lancet journal. So the novelty of this study is literatures indicated that the treatment for achondroplasia has been focused on the management of symptoms. So now the recent research is focusing on therapeutic manipulation of fibroblast growth factor receptor 3 activity with the C-type natriuretic peptide, as this might be associated with increased skeletal growth. So this open label study suggested that Vosoritide administration might increase the growth velocity in children with achondroplasia, and this study is the first phase 3 randomized double-blind placebo-controlled study done to assess the effect of Vosoritide on growth in children with achondroplasia. So this was the first study which takes to phase 3. So if this phase 3 means it has passed all the in vitro, in vivo, the phase 1, phase 2 clinical trials, and now it is in the phase 3 clinical trial, and it is a randomized double blind. Double blind means the participants as well as the providers, both they don't know what drug they are giving. Placebo controlled means one is a standard the drug which is to be tested, and the other is a placebo. And it's that's what. So it is a phase 3 randomized double blind placebo controlled study. Now talking about achondroplasia, we know achondroplasia is a disease where it gives a short stature. They have macrocephaly, frontal bossing, mid-face hypoplasia, rhizomelia, which is shortened limbs, especially the proximity, trident hand, and then hand becomes like this, and bowing of tibia. So all these things are the characteristic features of achondroplasia. It can either be familial or it can be a mutation which can cause this disease. Familial means it is transferred from the parent to the offspring. Here there is activated mutation in FGFR3, which means there is increase in function of FGFR3 which causes this achondroplasia. And we can see the oral manifestation of achondroplasia patients, where there is normal mandibular growth but a retrognathing mandibular growth here. And here you can see the intraoral view, which shows a lot of dental caries that they mostly have anterior open bite, anterior reverse jet also can be present. So the maintenance of oral hygiene is also difficult for these patients. And the skeletal appearance lateral radiograph, it shows a retrognathing maxilla, and it shows a skeletal prognathing mandible, but actually the mandible will be of normal growth and the maxilla is alone affected. So what happens in achondroplasia? There is a receptor called FGFR3, and this receptor is mutated. And what is the function of FGF? FGF has to function of FGFR3 is to inhibit the chondrocyte proliferation. So this FGFR3 acts on chondrocytes, which means all the intramembranous or endochondral ossification alone is affected, whereas the intramembranous ossification is not affected, and that might be the reason for the normal mandibular growth and the retrognathing affected midface region, which is by endochondral bone formation. So so FGFR3, if it is activated, it will inhibit chondrocyte proliferation and differentiation. There is impaired endochondral ossification, where the proximal segment of the is shortened. Why? The axial bones are spared because mostly the skull, the hyoid or the vertebral column are by endochondral formation, intramembranous ossification. The extremities and the other bones which I mentioned in the maxilla and the midface region are by endochondral bone formation, and that's the reason there is a defect in that area. Whereas the intelligence is normal, the axial skeleton is normal, the reproductive system is normal, and they have a normal lifespan. Other than the short stature, they don't have any anomalies. So this is how the mutation happens, where the glycine is replaced by arginine, and that causes the decrease in endochondral ossification, and the stature is shortened here. So for this they have used a drug called Vosoritide, which acts, see this is the normal FGFR3, where the FGF binds here, there is inhibition of this pathway and there is endochondral inhibition here. When there is a mutated FGFR3, there is more FGF to come and cancel the signal, and hence there is a defect in the endochondral ossification. So this Vosoritide, what it does, it goes and inhibits this pathway which inhibits the endochondral ossification inhibition. So thus it promotes the endochondral ossification. They have tried this drug on children to see the effect of this drug in increasing the height. So the aim of the study is to assess the change from baseline in mean annualized growth velocity. So this study was conducted for 52 weeks in patients administered Vosoritide as compared with controls who received placebo injections. So this is a placebo-controlled study. And the study design is, this is a phase 3 randomized double-blind placebo-controlled multi-center trial. They did this in many countries, not in many centers. In many countries they did. Where they gave once daily subcutaneous administration of Vosoritide at a dose of 15 microgram per kg of body weight with placebo in children with Achondroplasia. So all the children had Achondroplasia. They randomized the children into the control as well as the testing group. So the trial was done in hospitals at 24 study sites in 7 countries. So they did in Australia, Germany, Japan, Spain, Turkey and USA and the UK. So the participants were children with the age 5 to 18 who completed 6 months in observational group study and were ambulatory. So prior to being enrolled in this study, they had to undergo a 6 months observational growth study to check how the growth is for them, and then they were enrolled in this study. They did a genetic test to diagnose, and they excluded radiographic evidence of closed growth plaques, planned bone surgery or severe and untreated sleep apnea and other medical conditions or treatments which is known to affect the growth. So all these kinds of exclusion criteria were also there. Randomization was done by 1:1 using either Vosoritide or matched identical placebo. So matched identical placebo is both the medicine will look similar but the content will be masked. The randomization was done to the use of an interactive automated voice responsive or web responsive system run by ALMAC with the stratification according to the sex and Tanner stage. Tanner stage is the staging of the Achondroplasia condition. SAS version 9.3 was used to create a randomization list with the block size O applied with the each data. So they divided the patient list in blocks of 4 and they did the randomization. The participants, investigators, caregivers administering injections and assessors analyzing the outcome data were all masked to the group assignment. So all of them were blinded regarding the treatment. The patients received Vosoritide or placebo for the duration of 52 week treatment, and daily subcutaneous injection was given. Participants were required to attend the study site, visiting the screens at days 1, 2, 3 and months 3, 6, 9 and 12. The upper to lower body segment ratio was calculated as the ratio between the sitting height and standing height minus the sitting height. This is how they measured the upper to lower body segment ratio, because they wanted to measure whether there is an increase in the upper body growth or the lower body growth. And they also noted the serious adverse events and against the medications given. The outcomes were, the primary efficacy outcome was change from baseline in annualized growth velocity at 52 weeks, and the key secondary outcomes comprised of change from baseline height Z-score and change from baseline in upper to lower segment body ratio. Other secondary outcomes comprised of evaluation of the safety and tolerability of the medication, and evaluation of the pharmacokinetics and immunogenicity of the medication, and evaluation of change from baseline in bone metabolism markers including serum collagen tight marker, which is used for a biomarker for endochondral ossification. And imaging also they did, this provided measurements of the spine and long bones of the arms, legs along with the data regarding growth plate, bone mineral density and bone age. So apart from measuring the height, they also looked for the markers as well as the X-ray radiographic evidence of bone mineral density. The statistical analysis was carried out, and 55 patients planned in each of the 2 randoms. So they divided the patients as 55 in each group. All analysis were done SAS version 9.4 using the clock mixed procedure, and 6 pre-specified subgroup analysis were also done for the primary and 2 secondary key secondary efficacy endpoints. forest plots also provided overall summary of the primary and the secondary endpoints. The funding source. The funder designed the studies with the input from the investigators, provided the study medication and matching placebo and analyzed the data collected from the trial. So this study was funded by the pharma. Efficacy outcomes, the annualized growth velocity, which is the primary endpoint. The adjusted mean difference between the medication group and the placebo group was 1.5 cm per year in favor of the medication. And the least square mean change from baseline for the medication group was 1.71 cm per year compared to the placebo group. And the height Z-score, the medication resulted in a significant increase in height Z-score. In upper to lower body segment ratio, there was no significant change from baseline in the upper to lower body segment ratio. Safety and tolerability, adverse events were mild and transient, and the vascular effects this medication was associated with mild transient clinically inconsequential blood pressure changes that were self-limiting. Bone maturation and immunogenicity, serum collagen type 10 marker concentration, which is an indicator of endochondral ossification, were elevated in the medicated group, and bone age progressed normally in both study arms, and dual energy X-ray absorptimetry showed no significant changes in the bone mineral content or density. So this mineral content or density was not different in both the groups. So the limitations of the paper, it provides strong evidence for the short-term efficacy and safety of medication Vosoritide in increasing growth velocity, but its full impact on adult height, the quality of life, medical complications and proportionality were not mentioned. In the future direction, it needs a long-term study to understand the full impact of all these what I have mentioned, and the paper concluded that Vosoritide has a significant advancement in treating achondroplasia by promoting growth efficacy and safety in short term. However, continued research is essential to understand its full long-term benefits and potential impact on overall health and quality of life. Thank you.